to prevention and management. I welcome the panelists for today, Dr. Vijay Bose, Dr. Kesavan, Dr. Bharath, Dr. Arumugam, and Dr. Mithun Manohar. So I'll start a presentation. In between, we'll have a few breaks and discuss issues as and when we take the breaks. Yeah. So dislocation has been the old enemy for orthopedic hip surgeons for a long time, and it still remains the second most common cause of early failure after THR. And most of the time when we see a dislocation, we are additionally stressed as compared to, let's say, an infection or some other complication, because we know it is largely technical factors, although patient factors might be there. So I think it ends up putting a little bit extra stress on us. And if you look at bad news, over time, if you see the number of revisions due to dislocation and instability has remained constant or even higher than before. It's as a percentage of all the revisions. Maybe the other regions we've improved, but in dislocations, maybe that's not been such a drastic improvement over the last 15 years or so. We can see that from, let's say, 2012 to 2019, the percentage of instability contributing to revisions in the American Joint Registry is still fairly high, and it's even gone up. So if you look at factors affecting hip stability, I have divided them into soft tissue factors, which is capsule and abductors primarily, which most of the time lead on to early post-op dislocation. And next is those related to implant malposition, and that will be the prime focus of this session, resulting in impingement. And thirdly is the joint above, which has received a lot of attention over the last 10-15 years, which is spinopelvic abnormalities. And these causes give rise to often recurrent dislocations when they are not well controlled. Spinopelvic abnormality, we've already had a full session on this before, so I'll just keep it as a footnote of this talk. The main concentration will be on implant positions that lead on to impingement and subsequently dislocation. So if you look at soft tissue factors, the capsular closure is of primary importance, especially for posterior hip surgeons, where we use the posterolateral approach. And it's been quite well shown in literature that you need to have some kind of capsular closure to reduce the incidence of dislocation, especially when you do a posterior approach. There are different techniques, but some kind of capsular closure is definitely recommended. We can use drill holes to suture back the capsule, or you can do an end-on-end capsular repair depending on the type of capsulotomy. So just to illustrate a case in point, this was a lady who presented with acetabular loosening, and she had an acetabular revision alone through the posterior approach. Femoral component was in stable and 15 degrees of anteversion, and it was not changed. Being a revision scenario, oftentimes the capsular closure is kind of weak because of the change in offset, as well as the kind of suboptimal capsular quality of the soft tissues. And 1 month post-op, this was the picture. She came with this picture. She caught her foot on a mat and then had this dislocation episode. Maybe I'll take the panel on what what they find anything abnormal in this and what they would like to do here. Mithun, if you can probably set the ball rolling.
Yes, sir. So it's a early post-operative dislocation. Probably going by the talk, it might be a. It looks. Posture approach, no, sir. Okay.
Yeah, posterior approach.
Cup is a little bit too big. So any chance of impingement and then dislocation, sir?
Yeah,
Offset is low. Offset might be low. That could be a reason.
we can go back. That's the offset. It looks fairly good as compared to the opposite side.
Offset is okay. Probably capsular closure, as you were saying, they might not have closed it. Laxity, abductor laxity.
I mean, what would you do next? Obviously, generally, I mean, what I wanted to show here was we have got the cross table lateral view, and you can see that it is dislocated anterior. So
Anteriorly. Okay.
yeah. So you can see that even though it was a posterior approach, the dislocation has happened anteriorly, and that's generally to do with when you have to do a revision. A lot of the anterior capsule also needs to be dissected to free out and get the exposure necessary. So it has come out anteriorly. We did a close reduction, and this was the post reduction X-ray. So, how many of you would go in for a bracing or, not do a bracing for this and just, it was stable on table once the reduction was done. So anybody for bracing or no bracing for these patients? Bharath, maybe you can.
When we do for this thing, we always give a knee brace that's easy for the patient, and that prevent them from flexing their hip too much, and it doesn't have the the problem of having a true hip brace, and just put a knee brace that we use for TCAR, and that's what we use for all our recurrent dislocation patients.
Yes, sir. Yeah, I think for posterior dislocations, knee brace is something that I think that's a great idea because it prevents basically hip flexion. That's how it works. But this, as we were talking, this was an anterior dislocation, sir.
No, post revision, anterior posture really doesn't matter really. It's just that's how it just floats out. Just soft tissue laxity there and all that. That's why the rates of revision or rates of dislocation after revision are so high compared 10 times that of a primary. So the rules of primary THR, anterior and posterior really does not apply to revision scenario.
No, this patient on Bharath, please go ahead.
Sir, in this case, it appears that the cup is excessively anteverted and was placed. That was maybe the one reason that we can think it could have been dislocated anteriorly. And of course, in a revision scenario, the soft tissue structures are completely lax. And also, it seems to be the head size is smaller. It seems, I think it's a 28 mm head. So that's also an added thing for a dislocation. And the revision scenario, the cup is too big for the acetabular socket. I understand. So therefore, the reason is it's an implant to implant impingement that has occurred posteriorly and it has dislocated anteriorly.
Yeah, anteversion, you can see the cross table view. It's a fair idea of, how anteverted a cup is. It doesn't look too bad. So, yeah, I think the question, she was put on a bracing. So for posterior dislocation, one way is to put the knee brace on because it prevents hip flexion. The other is to, or a more cumbersome way is to give an abduction brace and restrict flexion. Both of them are an abduction, but for a posterior dislocator, generally we have to restrict flexion. For an anterior dislocator like her, it is still an abduction brace, but we limit the extension. It was kept in about 45 degrees. Even if you keep it in 45 degrees, it allows extension up to about 10-20 degrees. So So limit extension in anterior dislocator. So this is the brace that she got, and this was an X-ray from 2012. So those times you can see that it is a very old AML stem, and that was the head that was available. So this was treated with bracing, and she has remained, stable for after that. So if it was impingement, then generally it leads to more often recurrent dislocations. But this lady is settled, so most likely I think it was a post-revision soft tissue deficiency. I think the point, I think we don't use it that often. So, but bracing is, for posterior dislocators, knee bracing is an excellent idea because it limits hip flexion. Anterior dislocators are a little bit more tricky because you have to limit extension, and the abduction brace can be programmed to do that. So this was 6 months after her, and she's been stable. So this was a 73-year-old lady who had an intertrochanteric hip fracture. And this was the first hemi done. You can see it was a non-modular hemi that's been cemented in place. And she had this GT that was not reconstructed, which means that the abductor mechanism was not... we don't know the status, whether there was a vastus attachment distally or not, but this is how it looks on the X-ray immediate post-op, and this is how it looks at the time of dislocation. She dislocated, and you can see that the GT fragment is lying right here, and dislocated several times in a span of 2 months. So this is what we found at revision surgery. The GT fragment was separate. There was no attachment distally. And what would the panel suggest here for the next step?
I think a revision with the reattachment of the greater trochanter will be necessary without saying. But in addition to the fact that these trochanteric fractures have a lot of problems with length restoration as well as offset, it may be a good option to have a dual mobility also.
Yeah, so I think this is a non-modular stem. So what would you do with this? Would you take it out, or this is a non-modular stem hemi?
The first choice is to reduce the hip, open it intraoperatively, assess, try to pull the trochanter and hold it with a clamp and see if it restores. If it's very stable, then I would leave it, considering it's a smaller surgery, but it's unlikely. So it will be the best option to do a full revision with the reattachment of the trochanter with the dual mobility.
I will look at the version of the component. If it is acceptable, I will do a GT reconstruction. But if it's not acceptable, straight away I will revise it to a dual mobility.
Don't have the CT here. We had a CT done to assess this version. It was about 13-14 degrees stem version as compared to the posterior condylar axis. Stem version was okay, but the offset was reduced. So, would you do a full revision with an ETO for this, or what?
Well, if it is biomechanically not stable, then there's no choice. We have to go the full point.
Okay.
So if you are not expecting success with your this thing, there is no point trying to reconstruct just a GT and hope for the best.
Okay. So what
did you attempt like a bipolar or tripolar arthroplasty?
Yeah. So as I said, once it got, then the offset was low, and even with the clamp in, it was still dislocating with the GT clamp in. So what we did, you can see, was a cement in cement revision with an exeter kind of stem. So this helped increase the offset, avoided the need for a full ETO kind of approach here. And again, I retained the modular bipolar. She was a fairly old lady for whom bipolar had been done, and then so I retained the bipolar, didn't go for a THR here. So, and this was 2 years post revision. the GT, despite all those poorly looking fragments, miraculously healed well, and she's been stable. Yes, severe knee osteoarthritis, but she wouldn't go for another surgery because of this experience. Yeah, I think cement and cement revision is particularly useful for these early dislocators, because you don't have to go the full gamut of a very large revision. The stem comes out easily, a cement revision, because the cement mantle is new and fairly well fixed. This is a less morbid procedure that I think would avoid the need for a large revision here. Your take, sir.
You managed to, Arun,
Yes, sir. Sir, I think you're not able to hear you.
could manage to pull the stem out without an ETO, even though it was fully well cemented. Can you hear me?
Yeah, it was. Most of these stems are kind of smooth and polished, so they come out pretty easily without. I mean, the stem comes out. It is the trouble is with removing the cement.
Cement.
What was the initial approach used for this?
It looked like an anterolateral approach, sir. Because there was a lot of scarring on the anterior side. It looked like an anterolateral approach was what it looked like on the table. But here, when I went in again, I went through the fracture because there was a lot of scarring and tissues. I didn't want to take out the abductors again. And because it was the large GT fragment was there, I just took it out, flipped it over on the side, because there was no distal attachment to the vastus. So it just flipped over, and through the fracture, we did the surgery. So next is we'll go to instability due to impingement. So we all know impingement is a fairly established cause of dislocation in THRs and often leads to recurrent dislocations. This is, I think, one of the excellent studies on instability that I have seen. They had about 48 revisions for dislocation alone, and they saw, of course, it was an old study based on old implants, but more than over 94% of patients had evidence of impingement when they were revised for dislocation, which kind of tells us that impingement is one of the major factors when we come to dislocation. If it is a recurrent dislocation, more so. If it's an early dislocator, you could probably blame it on soft tissue factors, but if it is dislocating again and again, there is a more serious factor that is involved, and often it is impingement. So impingement, I think we can categorize into three types. One is component, then the second is component bone impingement, third is bone impingement, and we look at the three types separately. So component impingement is a very well-studied topic, especially if you have posterior instability, which is what many of us are worried about. It is impingement in flexion and internal rotation. The impingement happens in the antero-superior part of the cup, and it is often related to component retroversion. Either the femur or acetabulum is retroverted, and it impinges on the antero-superior part and dislocates posteriorly. Yeah. So if it is anterior instability, the impingement is happening in extension and external rotation. Might be a little bit of the case where we saw with the revision also. And happens in the postero-inferior part of the cup, and often because of excessive anteversion and leading on to anterior instability. Again, here the correction has to come in terms of the component position. So intraoperatively during a THR, if we find that the hip is unstable in either direction, we have to look for impingement at these places. And most of the time it has been studied, and acetabular position has been the major factor in terms of version as well as inclination. So that has been the commonest implicated cause in this kind of impingement. So if you have a cup that is relatively retroverted, like cup in 40-degree abduction and 5-degree version. When the femur goes into flexion and internal rotation, we'll see an impingement there, and that is often the cause of posterior dislocation. Bone on component impingement is again common but easily correctable. It is the prosthetic neck going and impinging against the anterior osteophytes and leading on to posterior dislocation. And if you see osteophytes like this protruding outside the acetabular component, we just have to pay attention and remove them to correct this cause of impingement. So fairly easily correctable, but not very uncommon. So especially when we give more anteversion in the acetabular component for posterior surgeons, we often notice this significantly. The third is bone against bone impingement, and it is often the GT that goes and impinges against the AIIS. And this is often attributable to loss of offset and length, horizontal offset as well as the vertical offset. The traditional approach has been to increase the neck lengths, meaning the larger 36 plus 5, 4 or plus 8. When you go to these head sizes, it pulls the femur away from the pelvis and reduces this cause of impingement. Use of high offset stems. And a third approach, when you cannot change all this, is to remove a portion of the anterior trochanter so that it doesn't go and hit against the AIIS. So we have the software-based assessment for this virtual range of movement. I'll just so it can put you in different positions of femoral flexion and extension and external rotation, and it can show you where it impinges. So for example, here you can see that it is impinging here. So this software can help you assess the impingement in a pre-plan. So this is a cup placed in 40 degrees abduction and 20-degree version, and it shows that there is impingement in the postero-inferior part of the hip when there is 10-degree extension and 30-degree external rotation. Now here, if we change the version of the cup or reduce the anti-version of the cup, then we can note that the impingement has gone away. So internal impingement, where the component is impinging against the acetabular lip, a simple way to deal with this is to change or correct the acetabular version. So that is what I think we can infer from this. Other patient, so here total hip has been planned for an AVN with secondary osteoarthritis. Initially cup has been planned for 40-degree abduction, 20-degree version, 54 cup with a 36 head. And because here you can initially plan with the 132-degree offset or 132-degree stem. So because it is not matching the length and offset, first we equalize the offset and length now with that 127. So now when we put it into flexion and internal rotation at 50 degrees of internal rotation and 90 flexion, you can see that the impingement is on the AIIS. This means the GT is going and hitting against the AIIS. This is external impingement or bone-on-bone impingement. So when the acetabular and femoral positions are fairly well aligned, this is what we are seeing more often because we've managed to correct the acetabular and femoral versions. Then this is the component that remains, despite having a good offset and length correction. This is the impingement pattern. This happens. So what would you recommend doing in this scenario when there is external impingement with length and offset restored?
For one, the 50 degrees internal rotation is quite a significant amount. Is that the normal amount you would test in this scenarios usually?
Yes, sir. I mean, the number is a little bit each. There is no set concrete number for that internal rotation, which is ideal for stability. It depends on the amount of usage that the hip is put through. But 40 to 50 degrees or 40 to, even 60 degrees is what most authors suggest for good internal or impingement-free internal rotation in 90-degree flexion. 40 is kind of minimum, 60 is kind of maximum, 50 is kind of mid-range. I mean, there is no set parameter in literature to say that you need to achieve this degree of internal rotation for it not to dislocate. But 50 is kind of medium range. There have been hips where there is, if there is, let's say there is a dysplasia hip, then I would prefer 60-degree internal rotation to be impingement free. But in a normal hip, this would be the impingement. That 50 is what I would get for my patients. Although literature is kind of 40 to 60 is fine.
But Arun, here what we are doing is we are stably in this animated image, what you're getting from the robot. Here the pelvis is completely fixed.
No,
You are just, yeah, that's what it is. You are playing around with the range of motion along the femur and say you are having a bone-to-bone impingement. Whereas in a live, when a patient is walking or bending or forward or doing all these movements, there is always a compensated movement in the spine. So the amount of the flexion, the degree you're demonstrating may not be the actual when when the patient is walking or doing extreme range of motion. So how you are so definite that this is the level of impingement that you're going to have it?
Excellent point, Bharath. So yeah, the thing is that the software does take into account the spinopelvic motion in sitting and standing. So we have to feed, I have not shown it here, but we have to feed, that's why it takes different values for stand and sit. So in stand, the sacral slope is fed, and in sitting also the sacral slope is fed. So it does take into account to as much as realistically possible the spinopelvic motion from sitting to standing.
Yeah,
So
but here what you're saying is your trochanter impinging on the ASS.
Yeah.
How much is that going to have a role in your inclination or your pelvic index incidence is going to change because it is an abduction kind of a impingement.
No, not abduction. This is a neutral abduction adduction. You can see the values are, sorry, I think I went back now.
Arun,
Yeah.
normal human is not going to go for 50 degrees of internal rotation.
Yes, sir. Yes, sir. I am not saying a normal human goes for 50
If
degrees.
it is going for a 50 degree of impingement, the maximum the patient is going to do is only 30-degree internal rotation, and he'll be more cautious. If at all we want to do that, is we have to see clinically whether it is getting impinged after 30 degrees or not.
So 30 degrees,
So you meant to say
there are a lot of studies from Japan.
50 degree, obviously, when the software is going to do only the femur, it is going to do the impingement, obviously, it will be going to show.
Sorry, can you repeat that?
Will increase the femoral version.
Yeah, that is true. But any patient falling total, I don't think they'll be doing for 50-degree internal rotation.
Yes, sir. I mean, 30 degrees, there is one paper from, I think, late 1900, before 2000 to kind of back that 30 degrees. But most, a lot of work from Japan, especially Professor Sugano, they recommend 40 to 50 degrees is what they recommend.
For the Japanese patients, not for the Indian one.
Indian patients, we don't have a published
The range of motion is better than the Indian one.
Yeah. So even there is American literature also. Australians have some publications. There is more publications from Japan. So there is some variability, but to back your number to say that 30 degrees is sufficient is very.
I'm just asking in curiosity whether your post-operative patients all are doing 50-degree internal rotation and you have any clinical demo of that. Just you have to check it out. Then only you have to plan for the impingement, how much it comes.
Sir, I think if you have some literature to back that 30 degrees is sufficient, then I'm happy to accept. I'll be more than happy to say that 30 is sufficient and get back to 30 without bothering too much. But that's not what the literature backed, and there is, for a specific population, there is very little backing. For Australian, even last week there was a meet where an Australian surgeon came. They are targeting about 50 to 60 degrees internal rotation for minimum. So 40 is minimum and 60 is maximum. What you target intra is patient may not achieve all that movement. So they target also 120 degrees flexion. That is also fairly common quoted in literature. 120 degree flexion and neutral rotation. That is another common target that is mentioned in literature.
Flexion is okay. Flexion is acceptable in Indian patients. I'm talking about only the rotations.
Yeah. Rotations.
Sir,
that's a personal opinion that you have, sir.
Sir, recommendation is, as you said, 90-degree flexion and 60-degree internal rotation to test stability.
So whether they get the degree of internal rotation, nobody knows. Yeah. So The thing I wanted to show here was that this kind of impingement will not be affected by changing the cup version. You can increase the cup version to 30 degrees, but still the impingement pattern persists. So changing the cup version does not affect this bone against bone impingement, nor does you using a dual mobility liner, that also doesn't change this pattern of impingement.
Obviously, then to increase the offset.
Yes, sir. So traditional approach exactly has been to increase the offset and length. So yeah, that is one way of doing it. As I mentioned earlier, one way of doing it is increasing the offset and length or shave off the portion of the anterior GT. So those are two common methods that have been traditionally taught. But one thing I wanted to show is the effect of femoral version, as Mithun was also alluding to. Here, initially, we had the stem version in about 15 degrees, 16 degrees. When we have increased it to 20 degrees, we can see that impingement pattern has gone away. So what I'm saying is acetabular version has an effect only on component impingement. However, femoral component version affects both component and bone against bone impingement because it is the GT against the AIIS. Femoral version affects both. Therefore, just let's say you have put the femur in retroversion and compensate with acetabular version alone, getting a good combined antiversion angle. CAF might still be good, but it will still not prevent the bone against bone impingement. So you have to get the CAA right as well as the femoral version right in THR cases to avoid impingement. So that was the point I was trying to highlight. So, I mean, you need not have the robot for all these assessments. Traditionally, we've been doing intra-op assessment of stability and to see how much internal rotation we are getting in 90 degrees flexion. We have the point on the figure on the left. And in anterior stability, we put them in extension and external rotation and check for anterior stability. You can see that we put it in 90 degrees flexion, neutral abduction, adduction, and we are able to get, this is about 60, 70 degrees internal rotation easily. And extension, external rotation, it is about easily 20, 30 degrees of external rotation. So here is where I think we should differentiate between component versus bone impingement. The way I have been doing it before I had the software also was to put the finger against the femoral neck anteriorly here and see if that is impinging against the cup. If that is the impinging point, then we have got the version wrong, so version needs to be changed. If it is not happening here, then we put the finger further along and you can feel the GT hitting against the pelvis. And in those cases, either you have to increase the neck length and or shave off the GT, because here you are at the trial stage, difficult to change the femoral version. So this approach, the thing is, if it is a version problem, increasing the offset won't help. And if it is a bone against bone impingement where the GT is sitting against the pelvis, changing the acetabular version won't help. I think those are points that I wanted to highlight here. So we have to find where it is impinging and correct accordingly. If it is component, then version needs to be changed. And once you've got all this in place, acetabular version can still be changed. It takes effort, but that's what would require a change. But if it is external impingement, then just increase the length and we'll get the impingement-free range of movement. Yeah. So any points that
Arun, for the sake of discussion,
yeah,
we completely agree with you that by increasing the version of the stem can avoid both the impingements. But doing uncemented, the wedge tapered stems, what we are using right now, how much you can really think that we can manipulate your versions? Most of the time, at the end of the time, when we use a final broach for the press fit stem, the inherent bone anatomy takes the version to its account. Okay, so how much you can really change whenever you use a double wedge tapered stem? Whereas if you use a cemented stem, maybe I completely agree with you. You can rotate, you can manage with around the versions. But using an uncemented stem, how much you really think that you can really increase or decrease your version?
So I think for an uncemented taper stem, maximum I think you can play around 5 to 10 degrees, not definitely more than that. There have been a few cases where I have converted to a cemented stem because the femur was retroverted, so it doesn't allow your go from retroversion to antiversion with the cementless component. There have been two cases where I used an intraoperatively a cemented stem just so that I could change the version. There have been two cases where I had the pre-plan, so I was able to get the diaphyseal fixation bone Wagner stem to change the version. So extreme cases you can do that, but with the use of a tapered stem, only 5 to 10 degrees is maximum. 5 degrees is definitely possible, 10 degrees in some cases, depending on how the fit is happening in the metaphysis. Yeah, you'll have to have a cemented stem backup, or if you want to really change too much of the version, then the only two options to use are like something like a Cone Wagner, SROM, or diaphyseal fixation stem.
I think the version can be changed significantly, and we do it in all cases. But the important thing is you have to start off like that, based on a starting point where you broach it, where you start anterior, posteriorly. So we do it in matter of in all cases. We try to either give more antiversion or less antiversion on every single case. And some of the cases we can have dramatically, if you consider the posterior neck plane to be the guide for your femoral native version, we can change it quite significantly actually. Yeah. But you must start doing it initially, not the last minute. After preparation, you cannot change, but you assess the native version and you say, okay, I need to, and that's what the software all allows you. You know the information beforehand that you are short in version or there's too much antiversion, and then you right from step 1 onwards, you have to go down that line. And I've got many pictures to show we can change quite significantly actually.
I think, sir, I just wanted to get your thought on this. Earlier, we are having a discussion of intraoperatively how much stability you would target in, let's say, flexion 90 degrees. How much internal rotation would you want your hip to have intraoperatively? There have been like various numbers starting from 30 to 60 degrees. Internal rotation is ideal for posterior approach hip.
I know, but I don't know whether you listen to my talks. Yeah, so I don't do intraop stability at all.
Yeah, I've heard that, but I wanted your point. Yeah, I think I've heard that.
So yeah, so if the native hip is stable, this also the native is impinging, unlikely to be impinging. So I understand what the maker was telling you, but this may be information that is the native hip was like that. So we are very happy to accept that. And the stability, as I say, always say, is with your capsule that is open. So it doesn't actually tell you what really the stability is. Unless you close the capsule, you won't know what the stability is. And we have now, it's not that I'm just saying that we have, not done for the last 10 years. We have not done any stability test.
Okay.
I understand it's a little radical concept, but that's what we have been doing.
Yeah. Okay, sir. So we'll go on to a couple of cases. So this was a 70-year-old female who had a THR for a femoral neck fracture and 2 episodes of dislocation. You can, on the X-ray, we can see that the cup looks quite antiverted, and CT scan also reaffirmed this same 61 degrees antiversion through a posterior approach. What next? How much version would you target when you go in again?
It will be based on the femoral version.
Femoral version was calculated, I think, stem 10 degrees antiversion in the femur.
Yeah, if 10 degrees, then I would go at least for 30 degrees of antiversion.
Okay. 30 degrees. Yeah. Okay. So, I think considering her age, this was my partner's case, not my own case. Just borrowed the X-rays from him. So this was done, and so they changed the cup version to about 25 degrees antiversion, put in a constrained insert so that because of the age and second surgery in a short span of time. And,
this is the good one, Arun, for a cement and cement. You want to change the version.
Yeah, it was already in 10 degrees anti-version, sir. So I think they did not change the stem. As I said, this is, I mean, I didn't do the case. It was one of my colleagues. So I just borrowed the case from him to show this acetabular position causing internal impingement and anterior dislocation. So I think because the stem version was reasonably okay, they didn't change it much. So they got away with the cup revision. This was at 1 year. Another case example, this again, Hemi had a non-modular uncemented Hemi for a femoral neck fracture and had a dislocation. You can see that the stem has, I think it was a case of the stem getting sunk, an uncemented stem getting sunk in a Hemi and then leading on to dislocation. And then shortly after, the primary surgeon converted into a cemented Hemi. Because the uncemented sunk in, they converted into a cemented Hemi and dislocated again. Any takes on the reason here?
Yeah, this is very typically, when the Hemi sinks, it'll sink into retroversion for sure. And everything, all your native landmarks will look completely, if you follow the landmarks there, you'll end up with retroversion. Common mistake to when you revise a Hemi. And then you will again end up dislocated. Yeah. So when you revise a Hemi, you need to be extra careful. Yeah. I suspect that is the reason in this case.
Yeah, I think, I mean, I got this patient at this stage. So what I think another thing was as compared to the other hip, the offset has also, I mean, gone down. When I went in again it was quite difficult to reduce it after increasing the offset. So I think they probably, I mean, again, it's a non-modular Hemi. So I think they just put it in wherever it was and the reduced offset contributed to the dislocation again. Again, probably I think I mean, when there is an offset issue, it is often due to external impingement. So that's what I was trying to show here. So I revised it with a dual mobility cup. Stem again revised to increase the offset and also to get a stem for a THR. So stem revised cement and cement technique again. And this was the picture immediate post-op, and this was at 3 months. You can see that as compared to the opposite hip, offset is reasonably well restored. But it was quite difficult to get it. I think a lot of scarring around, and it was fairly difficult to get this reduced after the offset was increased.
Yeah, the dislocated stem doesn't, will typically will show low offset because the limb is in the wrong position. You cannot take it that the offset is low.
Yeah, I'm showing here, sir. So you can see this is before dislocation. I don't know. I think I took this as a kind of, those are the clues that we got because it was already, you can see on the leftmost, this was after the cemented Hemi was done after the first dislocated uncemented. So you can see that as compared to the opposite hip, very low offset. So I think the last 5 minutes, I think we already had a session on the spinopelvic. So I'll just highlight a few points that is commonly noted in these things, not the elaborate version that we had before. So we all know that when a person, and Bharath was also alluding to that. So when person goes from standing to sitting, the pelvis tilts posteriorly, the sacral slope is reduced, and the acetabulum faces forward. And in an immobile spine, this mechanism is kind of lost, especially in a stuck sitting position. The pelvis does not tilt anteriorly with standing. The acetabulum doesn't face forward. It is called a stuck sitting position. And these are at risk of anterior dislocation. The common recommendation has been to decrease the version. And in a lordotic immobile spine, the kyphotic immobile spine that we often face is the Angstborn spine. That is the one that we often see. The Lordotic immobile spine is when it is stuck in standing position, meaning the pelvis does not tilt posteriorly with sitting. The acetabulum doesn't face forward with sitting, and it is stuck in standing position. So these people are at risk of posterior dislocation, often seen with the spine pathologies, especially like listhesis or previous spinal fusion. And here the recommendation has been to increase the anteversion. How much exactly to increase and decrease is fairly difficult to calculate, but general recommendations are to increase mostly by 5 to 10 degrees when this happens. So if you see a THR like Angspan like this, it's typically from a kyphotic spine. You can see that it looks like an outlet view with a wide obturator foramen and a narrow pelvic inlet seen. And in these cases, we reduce the version to very little, even though we do a posterior approach, even if we do a posterior approach. So last part is modifying implant factors in instability, head size, dual mobility, liners, lip liners, and constraint liners. So increased head size and dual mobility, both, as far as instability is concerned, both work exactly by the same mechanism. The first mechanism is increased head-neck ratio. When the head-neck ratio is increased, it decreases the impingement, or it increases the impingement-free range of movement that is shown in this diagram. So if you have a smaller head, generally it impinges, let's say at 110 degrees. If you have a larger head, the head-neck ratio is increased because the stem is the same, and it allows a wider range of movement without impinging component against component. Secondly, increased head size as well as dual mobility are seated deeper into the cup and therefore have an increased jump distance as shown here. For a smaller head, this will be the jump distance. For a larger head, this would be the jump distance. So increased head size and dual mobility work in the same mechanism as far as stability is concerned. Head size is the function through which dual mobility also increases stability for hip joints. And there have been enough number of studies that have shown that dual mobility acetabular bearings have a good role on improving stability in primary as well as revision hips. I'm not saying we need to use them for all, but when there is a question of instability with a lot of unknown variables, then dual mobility is an excellent go-to in these cases. Lip liners, we are often I think faced with the problem of getting only lip liners in many of our scenarios. Lip liner increases the jump distance. So let's say we use a posterior lip liner, it increases the jump distance posteriorly. It does not function in any other manner. That is the only way it functions. But we also need to understand that it comes with a price. It increases impingement in the opposite direction, meaning it reduces the impingement-free range of movement. And when you use a liner in one direction, you have to be always careful about instability in the opposite direction. But they have been used for a long time, and they are time-honored. So we can use it whenever there is a need to increase the posterior jump distance. Constrained acetabular inserts are totally different. They constrain the head to the cup and they have a locking ring, but they come with a higher price. So they have a fairly higher failure rate because it doesn't allow the hip to dislocate, but it puts more pressure on the acetabular bone interface. And therefore, they are generally recommended to be used in a well-fixed cup with minor positioning errors. So in those cases, it can work. If you put it in patients with a retroverted cup with a lot of impingement components, then it will pull the entire cup out or break the locking ring. So use with caution. So any point, I think before we go on to the last slide, anything else panel would like to say on constraint liners or dual mobility in particular?
One thing about the different types of dual mobility that we have. For example, we now have the Smith and Nephew OR30. The angle separated by the cup is only 170 degrees. So although you may get a dual mobility, you're losing a lot of arc of coverage by reducing it to 170. So if you're going to use for a dislocation case, for example, then you're really not gaining much, although it's still dual mobility. So all these things are very important. Yeah. So suppose you're doing a recurrent dislocation and then you want to use a Smith and Nephew, it may not be a great idea because you are getting increase in the head size, no doubt, but you're losing a very significant arc of only 170 degrees. So that's a problem that we have to keep in mind.
Yeah, great point. Excellent point, sir. I think the MDM from Stryker is a hemispherical cup design, while Smith & Nephew is a sub-hemispherical design. I think, yeah, that's a great point. Similarly, I mean, I had shown that case with dislocating bipolar, we had used a dual mobility generally, but the head size goes down. So actually, when we go from a bipolar to a dual mobility, whatever dual mobility we use, the actual head size actually comes down. Bipolar has a larger head than a dual mobility. But because the cup is shallow, or human acetabular cup generally subtends an angle of about only 155, 160 degrees, we get an additional component of stability from using a hemispherical acetabular socket. That's how dual mobilities have been shown to work in dislocating bipolars. Even though the head size goes down, the stability increases because we get a hemispherical shell.
That's right. Yeah. So similarly, Smith & Nephew has got the software now. And so if you use an R3 cup, and then you find that the impingement-free range of movement will be fantastic. Yeah. So there's always a yin and a yang to that. So if you use compared to a 180-degree cup, if you use a 170-degree cup, the impingement-free range of movement will be great. But what you'll be losing that is in the jump distance.
Jump distance.
So it's all a give and take everywhere.
What is the data on the wear characteristics of this poly in the dual mobility? Because you got a large head, so against the poly, does it wear out more?
No, sir. There have been, not too many studies, but there have been a few studies that have actually shown that wear in dual mobility bearings is comparable to or even slightly lower than standard bearings. And the reason they are pointing out is that most of the movement happens at the smaller diameter junction, which is between the head and the poly. The poly moves the bigger, or the dual mobility, the bigger bearing starts moving only when there is at the extremes of motion. So most of the movement is happening at the smaller diameter bearing. So they are saying that, whatever studies have come out, there is no study that would categorically shown that wear characteristics of dual mobility is, at least the modern dual mobility, is higher than standard bearing with the highly cross-linked poly.
Arun, for the take-home message, when do we really reserve this constraint liners on the contrary to the dual mobility? What are the strict indications for these constraint liners?
I think in my hands, I think I will use it only when the cup is well fixed. If the cup is really well fixed, osteo-integrated, then with minor positioning errors. Meaning if there is, let's say there is more of capsular deficiency in a revision scenario, where it is not a case of an extremely malpositioned cup, well-fixed cup with minor positioning errors, I think where you cannot get in a dual mobility liner. It may not.
That is one indeed. When you have a complete abductor deficiencies, you would prefer a dual mobility or you go for a constraint liner? In neuromuscular conditions, or your abductor is gone.
So for neuromuscular conditions, I think dual mobility has been shown to have a good result as well. If you are putting in a constraint liner in a primary cup, wherein you are fixing a new cup and using a constraint, then the chances of failure are high because it transfers all the stress to the acetabular bone interface. So if you already have a good cup where it is you are not worried about the cup pulling out, then that is a good case for using a constraint insert. Even for abductor deficiency as well as for neuromuscular hips, dual mobility has been shown to have a good stability.
With the abductor deficiencies, I think constraint liners are more preferable than the dual mobility. That's what the literature says. I do agree with that. Early, when you're doing a primary hip, there is high chance of the osteointegrations and all those stuff, but you're going to have a dislocation again in the early post-op. So it is better when you have a complete deficiency of the abductor, soft tissue laxity completely gone, then a constraint liner would be a better option than a dual mobility.
Yeah,
Is that right, sir? Vijay,
Literature
sir?
supports that, Bharath. Yeah. So the literature is equivocal on that. They
Yes,
both act by different mechanisms, obviously. Yeah. So the absolute indication is, when you use one of this, and then also the constraint liner is a very pro-impingement device. So typical
Yes, sir.
use would be a well-integrated cup, which is slightly open. That would be the ideal indication for you to use a constraint liner where you don't risk impingement. So if you have a relatively closed cup, and then you put a constraint liner, it will impinge and pull out for sure.
Yes, sir.
Yeah. So those are things, but the endoclinic where they use this large mega cases, they find that if the constraint liner fails, they do dual mobility, and dual mobility fails, they'll do constraint liner.
Constraint liner.
Because both work in different mechanisms, and for a particular case, one may work, one may not work.
Yeah, I was about to say the same thing. If you put in a primary cup with the dual mobility, and if it is dislocating down the lane and the cup is well fixed, that is a good case for using a constraint liner. Exactly what Bose is saying. Because by the time the cup would have integrated, so you're less worried about using a constraint liner.
It's the last option,
Yeah.
whatever.
So
The failure rate of constraint liners are very high compared to dual mobility. That you have to keep in mind.
Yeah, within 5 years, they're gone.
So I think just to come to the conclusion slide, we can have some more discussion if there are questions. So identify the cause and correct. I think that will be the first thing to press upon. If it is a capsular deficiency or an abductor deficiency in the early postoperative period, correct that. But I think impingement has been the major cause of recurrent dislocations in studied series. It can be component against component, where we have to mainly correct version, either acetabular or femoral. If it is component against bone, it is fairly easy to correct. This is mostly for the first time primary. If there is feeling unstable intra, we have to look at whether there are anterior osteophytes hitting against the femoral neck. The bone-on-bone impingement, increasing the offset in terms of neck length, high offset stem, those are options. Or as I've more recently learned from use of this software, femoral version affects this bone-on-bone impingement, whereas the acetabular version does not. And the important point is, if it's a component against component impingement, there is no point increasing the offset and trying to get the hip more stable, because a common misperception I had in my early days was if the hip was tight, it was more stable. But if it's a component against component impingement, putting in a larger neck length doesn't compensate. Similarly, if it's a bone-bone impingement, changing the version of the acetabular component will not affect it. You have to either increase the offset or change the femoral version. Spinopelvic abnormalities we have to keep in mind, especially in patients in our situation, angstpons and patients who had spinal surgeries, and adjust accordingly. Lastly, the implant modification in terms of a larger diameter head, bar dual mobility, both work by the same mechanism. Lip liners when there are minor increases in jump distance required, and constraint liner in very specific situations. Yeah, I think that's the end of my presentation. If there are any more things that you would like to add on.
Is there any role for a posterior lip augmentation device for a recurrent dislocator? Is there any role at all in this modern time?
You're asking about a lip liner, or there is a specific posterior augment device that I've seen in some presentations, but I've not used or seen it in action here. Which is the one you're asking, sir?
Augmentation device.
Yeah, augmentation. Yeah. So I think, yeah, if there are no other options, I think then that is one way of increasing the jump distance. But I don't have an experience. I don't know if anybody else has used that augmentation.
We've done a lot in the UK where we used to have only 22 heads those days, and then when it dislocates, then we'll cut a poly from a cup and then we'll screw it onto the existing cup and things like that. All this have no role now with the modern devices that we have. In fact, that was the standard care of dislocations because the compound positioning will be right. Although we didn't understand compound positioning that well those days, the only tool that we had is to do something about the cup with the 22 head. It was intrinsically unstable, so we'll put this thing and screw onto the cup. And I think Dr. Pachuri also has done a lot of those cases those days, I think. I revised a few of that. So these days, it doesn't have any role.
Sir, that's it, sir. No more doubts, questions. Sir, thanks, sir, for the wonderful presentation. I thank President Dr. Arun Kannan and all the panelists, and especially the sponsors, Mithun Manohar and OrthoTV, for this nice session. Sir,
Well done, Arun. Nice presentation.
Thank you, sir.
Thank you. Thank you, sir.
Thank you, Arunji. See you.
See you.
Thank you, Arun.
Thank you.
Lovely presentation, Arun.
Thank you, sir.
A good presentation.
Thank you, sir.
Hello, sir. Can I end this session?
Yeah, sure.
That's it, isn't it? There's nothing else
Yes, sir. That
happening.
nothing else, sir.
Okay, good night.